Hello students. Welcome to Concepts of Care for Patients with Stomach Conditions. We are going to review in this chapter gastritis, peptic ulcer disease, and gastric cancer. This is a very, how can I describe it? This is a very important chapter, okay? Because we're going to review many concepts related not only to the gastrointestinal, but also this is going to extend at some point to previous concepts that we review in hematologic disorders and also other pharmacologic concepts, okay? So please take a look to your dumping syndrome, to hematemesis, dyspepsia, gastrectomy, peptic ulcer disease. I want to emphasize this is a condition that results when GI mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsin. And we're going to clarify the mechanism of action of pepsin. Also, review peritonitis, an abdominal infection in which the abdomen is tender, rigid, and board-like, and stress ulcers, acute gastric mucosal lesion occurring after an acute medical crisis or trauma, such as sepsis, head injury, or surgery. So the most important concepts, infection, and the interrelated concepts are going to be inflammation, nutrition, and pain. Diseases that affect the stomach include gastritis, peptic ulcers, and cancer, as I mentioned before. Each of these health problems can result in impaired or altered nutrition. Inflammation and infection can cause pain and discomfort. So let's start with gastritis, and I'm going to play the video on how the stomach works so we can get a very nice idea of what is coming in this chapter.
What exactly happens in our stomachs when we eat? Even before we have taken the first bite of a meal, the brain sends impulses to the stomach. These impulses start the production of secretions in the stomach, and the upper part of the stomach, which acts as a reservoir, expands. The food passes into the stomach through the cardia at the stomach entrance. This is a muscle that acts like a valve, closing the top of the stomach. The top part of the stomach, the fundus, is where food and the air that we swallow with every bite is collected. This is where the stomach volume starts to adapt. The fundus is an extremely adaptable structure. The more food goes into the stomach, the more it actively expands. In the middle part of the stomach, called the body, gastric juice is produced and mixed with the mass of chewed food. The main component of gastric juice is gastric acid. This eliminates bacteria in the food and also helps to prepare the food for the following stages of digestion. The muscular contractions of the stomach wall churn the food mass and mix it with gastric juice. 3 contractions per minute move the food mass back and forth. After a certain time, the contents of the stomach are adequately broken down and mixed, and are passed in small quantities into the intestine via the pylorus. As the stomach empties, it gradually returns to its previous size.
Bayer. Science for a better life.
Okay, thank you so much. So far we understood that we have the fundus at the top, right, in which the food enters through the esophagus by the intervention of the lower esophageal sphincter. And then in the body of the stomach is the acid produces, the one that is going to decompose all the food that we eat. And also the muscles of that area are going to promote the passing through the pylorus. Okay, pylorus is going to be one of the structures that are going to have crucial role in all the diseases that we're going to discuss. So you need to master your anatomy, your map, as I always tell you, okay? Okay, let's continue. So gastritis is the inflammation of gastric mucosa, the stomach lining. Can be classified according to cause, cellular changes, or distribution of the lesions, and can be erosive, causing ulcers, or non-erosive, okay? Acute gastritis typically heal after several months. This is not true for chronic gastritis. Okay, in the pathophysiology, we have prostaglandins, and you're gonna ask me, maybe, Professor, what is prostaglandins? Prostaglandins. These are lipid-like hormones. They are having a type of hormone properties. They regulate, coordinate different functions in the body and give us specific instructions about what and when function needs to be done. Those are prostaglandins. They are different from hormones because your endocrine system glands don't release prostaglandins into the bloodstream like they do with hormones, right? So prostaglandins instead are made by the tissues at the site of the action. Either the site of damage, the site of infection, they are going to create prostaglandins. And they are hormone-like chemicals that cause inflammation, pain, and fever. Those are prostaglandins, okay? So the prostaglandins provide a protective mucosal barrier that prevents the stomach from digesting itself. If there is a disruption in the protective barrier, mucosal injury can occur. And that's what we need to prevent, because the mucosa is the one who is going to protect the lining of the stomach. The resulting injury is worsened by histamine release and vagal nerve stimulation. Hydrochloric acid can then diffuse back into the mucosa and injure small vessels. This back diffusion can cause edema, bleeding, and erosion of the lining of the stomach. So, inflammation of the gastric mucosa or submucosa after exposure to local irritants or other causes can result in acute gastritis. So that's the definition, right? The early pathologic manifestation of gastritis is a thickening, reddened mucous membrane with prominent rugae or folds. Diagnosis cannot be based solely on clinical symptoms. So if the stomach muscle is not involved, complete recovery usually occurs in a few days with no residual evidence of gastric inflammation. Meaning, if the causative agent is corrected, right, and maybe there are dietary changes, lifestyle changes, the mucosa can recover in a few days. But if the muscle is affected, bleeding or hemorrhage may occur during an episode of acute gastritis. The long-term use of non-steroidal anti-inflammatory drugs, NSAIDs, and please remember this, because these are the causing factors of gastritis, peptic ulcer, and gastric cancer. Okay, so all the conditions that I just mentioned is that is like in a step, like a pyramid domino effect. Okay, so you start first with gastritis, then the problem is going to increase to peptic ulcer, and then gastric cancer. So the long-term use of non-steroidal anti-inflammatory drug NSAIDs create a high risk for acute gastritis. NSAID inhibit prostaglandin production in the mucosal barrier, and we know the prostaglandin is going to protect, right, by inflammation, by fever, by pain, because it's going to wake up the immune system in order to get the protection, right? And those symptoms that I just mentioned are the signals of the immune system working to protect the body, right? So the NSAIDs are going to inhibit prostaglandin production. Other risk factors include use of alcohol, coffee, and caffeine, okay? Stress and cigarette smoking are considered a risk factor for the development of acute gastritis. So keep remember those because these are good to know. NCLEX alert risk factors of gastritis. They are going to come in your NCLEX. They are going to ask you. Local irritation from radiation therapy and the accidental or intentional ingestion of corrosive substances, including acids or alkalis, may also cause acute gastritis. Steroids, aldosterone antagonists, and selective serotonin reuptake inhibitors, your SSRI, these are your depression medications, right? Can contribute to gastroduodenal inflammation and ulceration. So here we are mentioning gastroduodenal. This is going to be the gastric area, the stomach, pylorus, and duodenum, okay? Chronic gastritis appears as a patchy, diffuse inflammation. This is chronic gastritis. That's why I changed the color. It's another topic of the normal lining of the stomach. As the disease progresses, the walls and lining of the stomach thin and atrophy. This is a chronic state. The function of the parietal, and we know that the parietal cells are in the fundus, which is the upper part of the stomach. The parietal cells decrease and the source of intrinsic factor is lost. Intrinsic factor is critical for absorption of B12. When body stores of B12 become depleted, pernicious anemia may result. And I want to emphasize parietal cells are epithelial cells in the stomach that secretes hydrochloric acid and intrinsic factor. These cells are located in the lining of the fundus, as I mentioned. Intrinsic factor is required for the absorption of B12 in the diet. A long-term deficiency in B12 can lead to megaloblastic anemia. Megaloblastic because those are the anemias that are having the MCB, right? The MCB is going to be high in your blood work, okay? Okay. The most common form of chronic gastritis is caused by Helicobacter pylori, okay? I just remember that maybe you don't remember what is MCV. It's the mean corpuscular volume. Mean corpuscular volume. In megaloblastic pernicious anemia, those numbers are high, okay? The most common form of chronic gastritis is caused by Helicobacter pylori. The host response to the H. pylori infection is activation of lymphocytes and neutrophils. Nurse love to monitor your neutrophils. Nurse love your lymphocytes, and the monocytes are not participating here. This results in a release of pro-inflammatory cytokines, and we know that these are cells that send signals for the immune system to start working that damage the gastric mucosa. Let me review this sentence. The host response to the H. pylori infection is activation of lymphocytes and neutrophils. This results in a release of pro-inflammatory cytokines that damage the gastric mucosa, meaning that the cytokines are going to send signals and the overproduction of the immune system is the one who is going to damage the mucosa. Chronic local irritation and toxic effects caused by alcohol ingestion, radiation therapy, and smoking have been linked to chronic gastritis. Again, chronic local irritation and toxic effects caused by alcohol ingestion, radiation therapy, and smoking has been linked to chronic gastritis. Surgical procedures such as pyloroplasty can lead to gastritis by causing reflux of alkaline secretions into the stomach. Okay, so here we are entering a very specific zone. Okay, so first of all, pyloroplasty is a surgery that widens the pylorus. When your pylorus is thick or narrow, it is difficult for food to pass through. I want to present to you different concepts. First of all, let me review this sentence. Surgical procedures such as pyloroplasty can lead to gastritis by causing reflux of alkaline secretions into the stomach. Okay, first of all, we need to understand that the pH of the stomach is around 1. It's very acidic. Okay, the pH of the stomach, follow me guys on this. pH of the stomach is 1. After the pylorus, you have the duodenum. Now the duodenum has an acidic, and I'm giving you in the supplemental material a graphic, and you're going to be able to see the pH. There is a pH table, and also I selected another graphic where you can see more or less what area of the digestive system correspond to what level of acidity, right? So the duodenum is kind of neutral, meaning that it's 6 to 7, let's say between 5 and 7 of the pH. So it's less acidic than the stomach. So far, so good. So we have an stomach of pH of 1, which is very acidic. And then after the pylorus, the duodenum, okay, and the small intestine is going to come between 5 and 7. Okay, so that means even though it's still acidic, it's less acidic than the stomach. That's why when there is a pyloroplastic, this can lead to gastritis by causing reflux of alkaline secretions, meaning this level of acidity of the duodenum is kind of alkaline in reference to the stomach. So when the pyloro is not closing or working good, there's going to be reflux from the duodenum to the gastric. So that alkaline environment from the duodenum is going to go back to the stomach, which is more acidic. These changes in the pH is going to cause a bad environment. Okay, I hope you understand this concept. Okay, so not only the pyloroplasty, okay, is going to cause this reflux, but also Crohn's disease, graft versus host disease, and uremia can also precipitate the development of chronic gastritis. Chronic H. pylori infection and autoimmune gastritis increase the risk of developing gastric cancer. Autoimmune gastritis means that there are too many soldiers that are going to start attacking their mucosa in the gastrointestinal due to the presence of H. pylori. By the way, H. pylori has a spiral shape and is going to, they love to live under the mucosa, so you cannot see them above. It's going to be living under. Okay, patient and family education. And there's another concept that I need to talk to you about, uremia, because we were talking about that these alkaline secretions and these systemic disorders that are causing imbalance in the pH of the stomach can be caused by Crohn's disease, graft versus host disease, and uremia. Uremia, also known as uremic syndrome or azotemia, is a condition where there is an abnormally high levels of waste products in the blood due to kidney failure. This causes cramping of legs, headache, extreme tiredness, and vomiting. Okay? And patient and family education, gastritis prevention. So eat a well-balanced diet, we know that, and exercise regularly if possible, right? Avoid drinking excessive amount of alcoholic beverages. We talk about the NSAIDs. Avoid excessive intake of coffee, even decaffeinated, because coffee is very acidic. I have also provide you in the supplemental material a table in which you can see what type of food and their pH. Okay, so you can see coffee, tomato sauce, how acidic they are. Manage stress levels using complementary and integrative therapies such as relaxation and meditation techniques, because this is going to help you to prevent stress ulcers, right? And stop smoking, that's another one. Okay, so okay, health promotion, disease prevention. Stress reduction techniques can include aerobic exercise, meditation, and or yoga depending on individual preferences. Assessment, symptoms of acute gastritis is going to present as epigastric pain and dyspepsia. We know that that's an epigastric burning sensation, often referred to as heartburn. And I really suggest you to master all these definitions and specific terminology, because they are going to give you report using this terminology, right? In some cases, gastric bleeding may occur and manifest as hematemesis. This is vomiting bright red or coffee ground blood, or melena, dark tarry sticky stool indicating alcohol blood caused by digestion of blood within the small intestine. So we have hematemesis, which is the vomiting of bright red, and we have melena, which is going to be your dark tarry sticky stool. Gastritis, or okay, I want to say this because it happened to me before. So somebody gave me a report about a patient with gastritis, and they told me the patient had a melena presentation, a vomiting bright red. So melena is not the vomiting, okay? Melena is going to be present in the stool. Hematemesis is the vomiting. Melena is in the stool, okay? Gastritis or food poisoning caused by endotoxins such as staphylococcal endotoxin has an abrupt onset. Severe nausea and vomiting occur within a few hours of ingestion of the contaminated food. In some cases, gastric hemorrhage is the presenting symptom, which is a life-threatening emergency. Chronic gastritis causes few symptoms and less ulceration occurs. Okay, nausea, vomiting, or upper abdominal discomfort, periodic epigastric pain, and anorexia. So EGD, and we know EGD is esophagogastroduodenoscopy, meaning that the endoscopy is going to enter the esophagus, is going to travel through the stomach, and it's going to go all the way through the pylorus to the duodenum, okay? They are going to perform a biopsy, and this is the gold standard for diagnosing gastritis. Cytologic examination of the biopsy specimen is performed to confirm or rule out gastric cancer. To detect H. pylori infection using rapid urine testing cultures or molecular detection PCR DNA. The rapid urine testing when they have a piece of the biopsy, they put it on a specific container, and they are going to put chemicals, and they will know exactly what's going on. The results of these tests are more reliable if the patient has discontinued taking antacids and proton pump inhibitors for at least a week. So this is very important, and this is part of nursing care, nursing education. You need to tell the patient to discontinue your antacids and proton pump inhibitors, your PPI, for at least a week. Why? Because you want the symptom to present during the EGD. You don't want the effect of the antacid be present, right? So the symptoms is going to be hidden. Take actions, interventions. They have an exacerbation, flare up of acute or chronic gastritis that result in fluid and electrolytes imbalance, bleeding, or increased pain. So if they present with these symptoms, the patient will be seen in the acute setting. So if the patient is having a flare-up, is going to have fluid or electrolytes imbalance, bleeding, or increased pain, they are going to be seen in the acute setting. Acute gastritis is treated symptomatically and supportively because the healing process is spontaneous, usually occurring within a few days. If bleeding occurs, a blood transfusion and fluid replacement may be given. Surgery such as partial gastrectomy, pyloroplasty, meaning that they are going to correct the strength of the pylorus, and vagotomy may be needed for patients with major bleeding or ulcerations. So let's watch a video about how pyloroplasty is done. It's gonna be a short video. So there are types of pyloroplasty. You can see what they are doing. They cut the pyloral muscle, right? They make an incision, and then they're gonna suture in the other way. Okay. So that was pyloroplasty. There are multiple ways to either, let's say there is an obstruction in the pylorus, or the pylorus is not narrowing as the patient needs. So the food content is staying in the gastric in the gastric area. So that also increases the chances of more acid to be produced, right? So the food never passes through the pylorus. That's why they do this pyloroplastic. Okay. May need it for patients with major bleeding ulceration. Okay. Eliminating the causative factor is the primary treatment approach for acute gastritis. Right. Eliminating the causative factor. So avoiding caffeine, even the caffeinated, non-smoking, right? Reduce the alcohol intake. Okay. Okay, so all of these are going to reduce the gastritis. Okay, what's going on here? Why am I having this? Okay. Nutrition and drug therapy is crucial. So if we correct this at this level, when we are talking about gastritis, we don't need to worry about peptic ulcer, neither gastric cancer. Teach the patient to limit intake, caffeine, high acid content, which is tomato products, citrus juices. Lemonade is high acid. Bell peppers and onions. Hello. All of you that love your Philly cheese sandwich, which is full in bell peppers, onions, and meat, red meat. Bland, non-spicy diet and smaller, more frequent meals are better, okay, to treat this gastritis. Alcohol and tobacco should also be avoided, okay. When we talk about less alcohol consumption, I will strongly suggest you to avoid alcohol. Sooner or later, the alcohol is going to cause problems, especially if you're drinking spirits, right? Instead of wine. Okay. Okay, let's continue. H2 receptor antagonists, such as famotidine, are typically used to block gastric secretions. So you need to know your pharmacology for GI. Sucralfate and mucosal barrier fortifier may also be prescribed. So we have H2 receptor antagonist, famotidine, and we have another drug classification, sucralfate and mucosal barrier fortifier may also be prescribed. We need to fortify the mucosa, right? Antisecretory agents, proton pump inhibitors, PPI, such as omeprazole or pantoprazole. Omeprazole is your Nexium, may be prescribed to suppress gastric acid. Antacids used as buffering agents include aluminium hydroxide combined with magnesium hydroxide and aluminium hydroxide combined with simeticone and magnesium hydroxide. So what does buffering agents mean? Buffering agents means to keep environment as a constant pH state. That's why I spent a couple of minutes explaining the pH environment in this gastrointestinal. Okay, so antacids used as buffering agents, antacids used as agents to keep the environment at a constant pH state include aluminium, da 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 da. Calcium carbonate is also a potent antacid, but can trigger gastrin release, causing rebound acid secretion. Let's review these examples of drug therapy for gastritis and peptic ulcer disease. So we have the antacids. Antacids, follow me please, guy, on this. Increase the pH of gastric contents by deactivating pepsin. Okay, so what is pepsin? First, we are gonna watch a video about this, okay, so you can understand much better. And as you know, I always select very short videos.
Pepsinogen is the inactive form of the enzyme that must be processed before it is capable of degrading proteins. About 40 amino acids have to be removed from pepsinogen before it can be activated. This occurs in an acidic environment because the acid allows the protein to unfold, and then pepsinogen will auto-cleave itself and remove these amino acids and thus become pepsin, the digestive enzyme.
Thank you. So, in other words, we need pepsin in the stomach to be active in order to metabolize and break down the proteins. Okay? If we don't have the acidic environment, pepsin will never react, will never work. It will always be pepsinogen, which is not the active form of pepsin. So far, so good. So in order for us to metabolize, to break down the proteins, we need pepsin. And pepsin is going to be active only in an acidic environment. Okay? Okay, so when we get antacids, these antacids is going to increase the pH of gastric content by deactivating pepsin. Let's stop here and let's review. Dr. Matalana, I don't understand how antacids are increasing the pH. Because remember the rule of the pH. It starts from 0 on the left, then goes to 7, and then goes to 14 on the right. When the textbook is telling you increase the pH, meaning that the antacid is gonna move from 1 on the left, which is the acidic level of the stomach. Increasing pH means that the arrow is going to go all the way up to 5, 6, or maybe 3 or 4, right? So it's going to be less less acidic because it's increasing the pH, okay, from 1 to 3, 4. And when that happens, pepsin is not going to be in the proper environment because pepsin needs to be in the acidic environment of 1. So if you increase the pH and you move the pH to 3 or 4, pepsin is not going to work. That's the effect of your antacids. Okay? So it's kind of blocking the acidic effect. Okay, so which medications are under this category? We have magnesium hydroxide with aluminum hydroxide. Give 2 hours after meals and a bedtime. Okay. And use liquid rather than tablets. Do not give other drugs within 1 to 2 hours of antacids, right? And then assess patient for a history of chronic kidney disease. This is the most important part of the magnesium hydroxide. This is an NCLEX safety alert. So you need to assess patient for a history of chronic kidney disease. Hypermagnesemia may result, so we need to check magnesium in your CMP, your comprehensive metabolic panel, especially in patients with poor functioning kidneys that's causing toxicity. Assess the patient for a history of heart failure. Inadequate renal perfusion from heart failure decreases the ability of the kidneys to excrete magnesium, thus causing toxicity. And also, so everything in green here is high safety alert, right? The kidneys, the heart. And then whatever is in yellow is you need to monitor for diarrhea, and you need your nursing education, give 2 hours after meal, okay, liquid rather than tablets. Then we're going to go to another antacid. This is the aluminum hydroxide without the magnesium. So in this case, we need to observe for side effect of constipation, whatever is in green in this specific classification. Please double check on that. If constipation occurs, consider an alternative with magnesium antacid, because the magnesium antacid is going to cause diarrhea. This one is going to cause constipation. Aluminum causes constipation and magnesium has a laxative effect. Okay. Used for patients with chronic kidney disease. Aluminum binds with phosphates in the GI tract. This antacid does not contain magnesium. So that's the most important, constipation. And then you are going to your nursing interventions, education, give 1 hour after meals, use the liquid rather than tablets, do not give other drugs within 1 to 2 hours of antacids, right? You don't want to interfere with absorption of other drugs. So we completed this block of antacids. Now let's go to the H2 antagonists, your H2 antagonist blockers. Okay, so the fundamental role of histamine is to be a local stimulator of gastric acid secretion. So your H2, your histamine, is going to promote gastric acid secretion via H2 receptors. Your H2 receptors are found mostly in the gastric mucosa, parietal cells, right? In where hydrochloric acid is produced, smooth muscles, and heart. Okay? So we have the H2 receptors that they are going to be the conductor for the gastric acid secretion to occur. So we have the H2 antagonist blockers, meaning that they are going to decrease the gastric acid secretions by blocking histamine receptors in parietal cells. So we know these receptors are the ones that are going to promote the gastric acid secretion. So these medications, this drug class, is going to decrease, is going to inhibit the gastric acid secretion. So what medications are doing this? The famotidine, right? So you have to give this medication at bedtime because it suppresses nocturnal acid productions. Okay, give single dose at bedtime for treatment of heartburn and peptic ulcer disease. Peptic ulcer disease. Did you understand why this umbrella is called peptic ulcer disease? Right? Because it's all related to pepsin. Okay? Pepsin is the enzyme that is breaking down proteins with the acidic environment. Okay? So that is peptic ulcer disease. We are going to have different classifications. We have the ulcer, the stress ulcer, the peptic ulcer, the gastric ulcer, duodenal. Okay? We are going to talk about that in a few minutes. Now we have another class, drug classification is the mucosal barrier fortifiers, the ones that protect the stomach mucosa. That is your sucralfate and bismuth subsalicylate. So your sucralfate is give 1 hour before and 2 hours after meal and at bedtime. Food may interfere with drug adherence to mucosa. And for bismuth, we have to remind patients to refrain from taking aspirin while this drug. Aspirin is a salicylic acid and can lead to overdose, right? Okay. Now we have another classification is your proton pump inhibitors. So far, we review the ones that protect your mucosa, the one that is inhibiting the histamine to produce gastric acid, and the other one that is going to increase the pH, meaning moving from 1 to a higher level, and by doing this, they are deactivating pepsin, which is only acting under the pH of 1 in a very acidic environment. Now let's move to proton pump inhibitors, okay? Proton pump inhibitors suppress HK ATPase enzyme system of gastric acid secretion to suppress acid. Basically, it's going to suppress the acid, okay? Okay, so we have in this class omeprazole, your Nexium. Have patients take capsule whole, do not crash. Give 30 minutes before the main meal of the day. We have your lansoprazole, rabeprazole, pantoprazole. Rabeprazole is going to be given after the morning meal. This drug promotes healing and symptom relief of duodenal ulcers. Do not crash the capsule. Pantoprazole. Do not give IV pantoprazole with other IV drugs. The IV form is not compatible with most other drugs, and this is good to know for you whenever you enter the hospital environment and you have a lot of new residents coming to the hospital, and they are prescribing this medication in parallel to other medications. You are the nurse, you need to keep an eye on this. Esomeprazole assessed for hepatic impairment, patients with severe hepatic problems need a low dose esomeprazole. So you check here for liver. Don't give with another drugs. The same with pantoprazole. Okay, now we're going to the prostaglandin analogs. Stimulate mucosal protection and decrease gastric acid secretions. So this is different from your bismuth. Your bismuth is only going to protect your stomach mucosa, while the prostaglandin analogs is going to stimulate mucosa protection and decrease gastric acid secretions. Okay, do not administer to pregnant woman. This drug can cause abortion, premature birth, of birth defects. So here we have to keep an eye on avoid magnesium containing antacids. Misoprostol and magnesium containing antacids can cause diarrhea. Finally, we're having your antimicrobials, right? So we have the treat the H. pylori infection. We are going to have clarithromycin, amoxicillin, tetracycline, and metronidazole. Clarithromycin give with caution to patients with renal impairment, so clarithromycin check on your kidney functions. This drug can increase the patient's bone level and should be monitored, okay? Amoxicillin teach patients to take the drug with food or immediately after the meal. Tetracycline drug can cause the skin to burn as a result of photosensitivity. That's something that you should be already aware because you master your pharmacology class, right? And then metronidazole teach patients to take the drug with food. This drug can cause GI disturbances, especially nausea, and teach patients to avoid alcohol during therapy for at least 3 days after therapy is completed. So treatment of chronic gastritis varies with the cause. Elimination of causative agents, treatment of any underlying disease like chronic kidney disease, Crohn's disease, avoidance of toxic substance, alcohol, tobacco, and health teaching. Okay. Patients with chronic gastritis may have decreased absorption of B12, and we know why that happens, and sometimes require B12 injections for prevention or treatment of pernicious anemia. If H. pylori is present, the primary health care provider treats the infection. Okay, so you need to get deep into your laboratory work to see how is the B12, how is your RBCs, your hematocrit, your hemoglobin, to see if there is any anemia of what type, right? You need to check your electrolytes, you need to check your magnesium, your calcium, you need to check your kidney functions, your liver functions, right? Before advising, educating the patients about their treatment, the treatment that the doctor is going to prescribe. So we finish gastritis. When we come back, we are going to talk about peptic ulcer disease. Stay tuned. Thank you.